Hi, everybody. I'm Deborah Weinkert. I'm going to be talking about your diet and hypophosphatasia. Um, I want to make sure that everyone can hear me. So, okay. It looks like I'm looking in this presenter chat, hoping somebody will tell me if they can hear me. Oh, there we go. I can hear you. Excellent. Um, I'm sorry to disappoint. I'm not a dietitian. I know in the earlier session there was a comment that a dietitian would be talking about your diet and hypophosphatasia. I'm a pediatric rheumatologist. I had the pleasure of working with Michael White at the Center for Metabolic Bone Disease and Molecular Research at Shriners Hospital for Children in St. Louis for 10 years, where every child who got admitted had a 1-week dietary log that they had to bring. And we had a dietitian who would work with us and figure out how much minerals and what the overall diet looked like for that child. And then we had them in the hospital for 5 days and measured urine and blood and studied them deeply. Everyone was invited back to come back for, depending upon how severe their disease was, up until the time that they were grown-ups. So we did have a chance to see what the natural history is across childhood. And I'm saying this as if it's in the past tense. I left there in 2010 and then started seeing patients there again in about 2017. So they're still up and running. I get to come join them 3 or 4 times a year for about a week at a time. And I'm also working for industry as a consultant after having spent some time at Amgen. That's a brief history of who I am. So let me launch in to your diet and hypophosphatasia, food for thought. I'm going to start with some general, well-founded dietary advice. And if you found that when you go to the doctor, they don't tell you much about what you should be doing with your diet, it could be that that's because there isn't a lot of data out there that is specific to hypophosphatasia, but there is some. I'm going to give a few words about hypophosphatasia. If you went to Dr. Kishnani's lecture this morning, then some of this will be repetitive, but it's kind of hard to launch into this without making sure that everybody is on the same page. Then I'll talk about a few logic-based thoughts specific to hypophosphatasia, and then dietary thoughts based on studies that have been conducted in patients without and as well as with hypophosphatasia. Now, this is an important thing to keep in mind. Good medical advice depends upon your doctor having obtained a good history, physical, and laboratory evaluation. That's not happening here. So I'm providing food for thought, not medical advice. One question is, if hypophosphatasia is a highly variable disorder, which it is there any nutritional advice that likely applies to everyone with hypophosphatasia? And the answer is yes, because there's no reason you shouldn't be, as a baseline, following general dietary guidelines. And this is the website, health.gov dietary guidelines. They come out revised ones come out every 5 years. And the general dietary guidelines say that we should be having more vegetables, fruits, whole grains, and we should be limiting sodium, saturated and trans fats, alcohol, soda, and added sugars. And if you're very into the particulars, they actually give specific amounts on this website of different types of foods that we should all be eating. Okay, I thought this talk was about hypophosphatasia specific considerations. Next, you're going to tell me to get regular exercise, stick to a good sleep schedule, maintain good social interactions. Well, actually I am. And the reason is that unlike what I can tell you about the thoughts about hypophosphatasia and specific dietary thoughts, these things are very well studied in people in general. We do know that your overall health will be better if you can do these things: good sleep schedule, regular exercise, and the types of dietary advice that was on the previous slide, and good social interactions. However, not all RDA recommendations are appropriate for patients with hypophosphatasia, but unless your doctor tells you otherwise, they will assume that you are aware of and following standard dietary recommendations. People with hypophosphatasia may benefit from tailored recommendations for calcium, vitamin D, and sodium intake. First, I'm going to brush through quickly a few words about hypophosphatasia and genes. I know you guys are missing the genetic meeting, so I'll give it to you in 1 or 2 slides. And much of this was already mentioned in the previous talk. So hypophosphatasia is caused by mutations in the gene coding for the tissue nonspecific alkaline phosphatase. And here's my 1 slide on genetics. Each chromosome, you get 1 copy of it from your mom, 1 copy of it from your dad. Each chromosome contains many genes. The gene is the segment of DNA that tells the cell how to make a particular protein. And the Human Genome Project estimates that humans have between 20,000 and 25,000 genes. Not surprisingly, it basically means that all of us have a mutation in something. If you have hypophosphatasia, then you know one of the genes in which you have a mutation, because everyone with hypophosphatasia has at least 1 loss of function mutation in ALPL, which is the name of the gene that codes for tissue nonspecific alkaline phosphatase. However, that specific mutation or combination of mutations can be different from one individual to another. There are 400 different mutations that have been identified that can cause hypophosphatasia. And the inheritance for those who have severe hypophosphatasia is called recessive, meaning that they got a altered gene from mom and an altered gene from dad. Mild could either be recessive or dominant. They could have gotten an altered gene from mom or from recessive, altered gene from mom and dad, as I said before, was severe, or it could be dominant, in which they got an altered gene from the mom or the dad. Carriers, by the way, can also have mutations. They typically have only 1 mutation, but they have no disease. So, more information about tissue nonspecific alkaline phosphatase. It sits on the outside of cells in the liver, kidney, bone, teeth, and it takes phosphate groups off of molecules. And these are the natural substrates for this enzyme. Inorganic pyrophosphate. It's a potent mineralization inhibitor. And when you take the phosphate group off of inorganic pyrophosphate, it no longer functions as a mineralization inhibitor, and thereby, for however much you have taken off, and thereby you can then mineralize your bones. Pyridoxal 5-phosphate. It's the major active form of vitamin B6, and I will talk more about that towards the end of the talk. And phosphoethanolamine. It helps link proteins to a cell surface, and I'm not going to talk about that anymore. Hypophosphatasia severity varies widely, and it generally parallels the age of presentation. So here's one way to conceptualize it. If somebody has abnormalities in their skeleton that are noticed before birth, it might mean that they have perinatal lethal hypophosphatasia. However, there's also something that's called perinatal benign, not so benign some of the time, but that means that they had some abnormalities that were noticed before birth, but their clinical manifestations and the age at which they show other aspects of the disorder fall into the regular categories. It sounds esoteric, but we found that at least 10% of people with pediatric hypophosphatasia did have a presentation before birth. Now, the reason I've done this with these concentric circles is that if you have pediatric odontohypophosphatasia, then you have a limited number of symptoms. Mild childhood will have the same symptoms plus some, and then on through the rest of the severity. If you had childhood hypophosphatasia and you're now an adult, obviously you still have hypophosphatasia. So that's one form of how of a category of people with hypophosphatasia who are adults. Other categories are people who have had adult onset hypophosphatasia or just have tooth manifestations with the onset in adulthood. So for odontohypophosphatasia, there's early loss of baby teeth with the root intact, as is shown here. Before age 5, adult odonto is significant loss of adult teeth. And the key here is there is no x-ray or skeletal biopsy abnormality. So if someone with odonto goes and gets a biopsy, they do not have osteomalacia if the diagnosis is correct. And as I said, we've had an opportunity to follow kids with odontohypophosphatasia, which I do think is a good idea, about every 5 years for most of them, to find out whether or not they ever started manifesting other problems. Occasionally, someone who seemed to only have odonto will start showing an x-ray abnormality, but we certainly are not biopsying these kids. Most of them never have any problem beyond having a tooth problem. Childhood hypophosphatasia can be divided into mild versus severe. It has the early loss of baby teeth and the rickets. The fact that you can see rickets on x-ray is one of the things in children that helps one avoid a biopsy, because if somebody has osteomalacia as a child, they will show up with abnormalities on their x-ray. And a number of other abnormalities that I won't go through because Dr. Kishnani already did. Infantile hypophosphatasia has the things that are sometimes seen in severe or are seen in severe childhood hypophosphatasia, and sometimes other abnormalities. One of the things that I think is always worth mentioning is functional craniosynostosis. This is where the sutures of the skull are fused, but it doesn't look like it on x-ray. So that can be a tricky one. And adult hypophosphatasia, the skeletal disease typically shows up during middle age. And you can see the rest on the slide, and I don't want to spend more time on it. The point here is, with this wide a variation of clinical manifestations of hypophosphatasia, you can imagine that for dietary recommendations, one size does not fit all. So how do we decide what kind of dietary considerations one might want to think about? Well, first looking at logic. Look at the basis of the disease. Try not to make that worse. Hypophosphatasia comes from insufficient tissue nonspecific alkaline phosphatase activity. But if you find your ALP is changing, remember that your alkaline phosphatase normally changes with age, whether you've got hypophosphatasia or not. And so I don't think I would invoke that you need to change your diet because your alkaline phosphatase is changing. Think about where you are on this age scale, and it could be that it's just a normal change with age. So what are the dietary causes of a decreased alkaline phosphatase activity? There are many different causes of low alkaline phosphatase activity beyond hypophosphatasia. They don't occur all that often, but there are some, and this can occur in people who do not have hypophosphatasia. They'll have a low alkaline phosphatase activity, but theirs never goes back to normal. Theirs goes back to normal when you fix these. So deficiencies: starvation, zinc or magnesium deficiency, B12 deficiency, profound anemia, vitamin C deficiency, or excess, too much antacid, vitamin D intoxication. Each of these things can drop the tissue nonspecific alkaline phosphatase activity in somebody without hypophosphatasia. I have no reason to believe that couldn't also occur in hypophosphatasia. So does it make sense? Well, there are 2 zinc ions and 1 magnesium ion present at the active site of each of the alkaline phosphatase monomers. So not having enough zinc and not having enough magnesium, you can imagine that this protein would not work well. Here's just a repeat of the previous slide. And this is something that I think is quite important to talk about when talking about any kind of potential advice for people when you are not specifically making that advice based on your knowledge of that patient. The Goldilocks principle, not too much, not too hot, not too cold, you want it just right. Also called moderation in all things. If we took that previous slide and went to the opposite extreme, instead of starvation, you'd have obesity. Instead of zinc insufficiency, you'd have zinc excess, which can cause abdominal pain, diarrhea, nausea, vomiting. Vitamin C, if you have vitamin C excess, you do get side effects, diarrhea, abdominal bloating, and there's a lot of evidence that shows it increases your risk for kidney stones. What about vitamin D excess causing a low alkaline phosphate? Well, if you have vitamin D insufficiency, you now have an additional cause for rickets and osteomalacia in adults. So the key here is you don't want to go to any extremes unless you have been told by a physician who is monitoring everything that they want you to change your diet specifically in one way for you because of what they're finding in your labs. To do otherwise is making yourself a guinea pig in an unmonitored experiment. Okay, so let's look at other metabolic changes associated with hypophosphatasia. The bony problems are from poor mineralization of the skeleton. The primary minerals of the bone are calcium and phosphate. Since there's insufficient calcium and phosphorus in the bone in hypophosphatasia, should everyone with hypophosphatasia take calcium and phosphorus supplements as is done in other forms of rickets? No. Not unless you're directed to do so by the doctor monitoring your blood and urine minerals. Unlike other forms of rickets and osteomalacia, the circulating levels of phosphorus, calcium, and vitamin D are not typically low, and in fact, the blood phosphorus levels are typically high, and calcium levels can be high. Remember, hypophosphatasia bone disease occurs from the overabundance of an inhibitor, inorganic pyrophosphate. That's very different from somebody saying, well, you don't have enough calcium and phosphorus in your bones, here, take more. That's not the issue. It's that you have something inhibiting the ability of your body to take the calcium and phosphorus that you're exposed to and put it into bones. So how do you decide what to do about the diet for someone with abnormal laboratory values? In general, for any lab, it's your doctor's job to figure out, is this lab normal in this particular patient under these circumstances? The normal range that's listed on the printout might not apply to you. Some labs may vary based on age, gender, timing of the physical exertion prior to obtaining the lab, your last meal, time of day, etc. So you really do need to have a doctor interpret the labs, even if you've got a printout telling you what they're calling the normal range. Is it normal given the values of this patient's other labs? A lot of lab values influence each other, so we'll talk a little bit about that in a minute. And you have to look at it in context, not just one lab at a time. So let's say that a doctor decides that your laboratory value is abnormal. Is it something that's expected to cause trouble and needs to be fixed? Is it something that is expected to do no harm, so leave it alone, because otherwise you're basically doing an uncontrolled experiment? Or is it your body's way of protecting you because something else is going wrong? In which case you'd probably leave it alone. So all of the food for thought comments on the next slides are intended to help you in your discussion with your doctor. These are not recommendations. And I'm just reminding you that even if you have results of your labs, your doctor has a more complete picture of your health, growth rate, current diet, insight into what can affect the lab test, and the laboratory in which it was run. Maybe the machine's not working. And we do find this from time to time. We'll have a group of patients all within a couple of weeks I'm not talking about Shriners Hospital for Children in St. Louis. I mean we as physicians. And sometimes you'll just see a bunch of labs come through that don't make sense to you. And so you call up the lab, you say, I don't think this makes sense. Is there any chance your machine's not working? And every so often, the answer is, oh yeah. So again, I'm referring you back to your doctor. Your doctor is the one who has insight into what's going on. The food for thought comments also assume that there is nothing else going on that might be governing how your body controls mineralization that's not quite working. So let's talk about calcium and vitamin D. Let's say your doctor measures things and you have a high urine calcium. A high urine calcium may increase the risk of depositing calcium in the kidney, and so the doctor may suggest that you increase fluid intake to dilute your urine. The doctor may suggest that you decrease your calcium intake to protect your kidney and bones, and your doctor may look at other tests to help decide how to further modify your diet. And here are some of the other tests that the doctor might look at. If you have a high urine calcium and a high urine sodium, your doctor might ask that you restrict your sodium intake first. It's not a bad idea for any of us on a Western diet, because a high urine sodium pulls calcium out into the urine with it and thereby can increase your urine calcium. If you have a high urine calcium and a low fasting blood parathyroid hormone, let me first take an aside. PTH, parathyroid hormone, is a hormone that's important for bone health, and it's highly influenced by changes in calcium. The story for PTH is a lot more complicated than that, but for now that's probably all we need to know. Lowering the dietary calcium for somebody with a high urine calcium and a low PTH may allow PTH to return to the normal range, and having PTH in the normal range is good for bones. All right, here's another scenario. Instead of a high urine calcium, let's say somebody has low urine calcium. After also checking PTH and vitamin D, your doctor might suggest that you increase your dietary calcium intake to provide more mineral for your skeleton and make healthier bones. If somebody has a low urine calcium and high PTH, then that might indicate that your system really is able to use more extra calcium. Increasing dietary calcium may give you more mineral for making stronger bones and bringing PTH into the normal range. For each of these, there are other potential possibilities to explain these types of laboratory outcomes. So I really would encourage you to go back and talk to your doctor. You're going to get tired of hearing me say that. If you have a low 25-hydroxy vitamin D, your doctor may prescribe vitamin D to normalize your blood levels of vitamin D. Because remember, a very low vitamin D can cause a different type of rickets or osteomalacia, and you don't want two types. But a very high level of vitamin D can cause anyone to have a low alkaline phosphatase. So here's a classic Goldilocks scenario. Just as a note, vitamin D is a hormone which helps the absorption and utilization of calcium. So the conclusion for calcium and vitamin D is adding extra calcium and or vitamin D to the diet of a patient with hypophosphatasia might be needed for some people and might cause problems in others. Also note the optimal calcium and vitamin D intakes for each person with hypophosphatasia is expected to change over time. It can be influenced by age, growth, change in medications. So it needs to be monitored, and you need to get specific advice from your doctor. Okay, I'm back to reminding you that good medical advice depends on your doctor having all of this information. This is not occurring here. I am only providing food for thought, and the normal range on the lab sheet may not apply to you. So what other ways can we try to come up with dietary considerations for people with hypophosphatasia? Well, you can extrapolate from people who don't have hypophosphatasia and then test in people who do. So for phosphorus, the influence of blood phosphorus level and of dietary phosphorus intake on alkaline phosphatase in 193 healthy young people without hypophosphatasia showed that lower serum phosphorus levels were associated with higher alkaline phosphatase activity, and that higher alkaline phosphatase activity occurred when the 3-day food record indicated that the dietary calcium and or dietary phosphate intake was lower. Now, it sounds like I'm saying the same thing twice. Lower serum phosphate levels are associated with higher alkaline phosphatase activity. Lower phosphate intake also led to higher alkaline phosphatase activity. When I say led to, that's a little bit of a misnomer because this was comparing one person to another rather than changing somebody's phosphorus intake. But nonetheless, they saw a correlation implying that for these healthy 20-year-olds, a lower phosphate intake seemed to decrease lower phosphorus intake seemed to increase the alkaline phosphatase activity. And these actually are two separate things because your serum phosphorus level can be controlled by something other than just your dietary intake. So what about people with hypophosphatasia? So in 2002, we presented the results of a 3-day challenge of only 3 to 4 children with hypophosphatasia in each group. There was actually another group, but this is the 2 groups that I'd like to talk about here. In one group, kids were given a phosphate supplement. This led to an increase in the inhibitor of mineralization, inorganic pyrophosphate as measured in the urine, and an increase in the circulating form of vitamin B6 called PLP, implying that this phosphate supplement blocked the alkaline phosphatase activity because those are 2 of the substrates for alkaline phosphatase. What about the group with a restricted phosphorus intake? They were given half of the recommended daily allowance. It led to no change in urine PPI and blood PLP in 2 of the 3 patients, but 1 patient, it did decrease these by 50%. Well, if you're looking for a quick fix, you might say to yourself, I'm taking phosphorus out of my diet. Not so easy, and maybe not such a good idea, and I'll tell you why in a second. First, what are the high phosphate foods? Fast foods, milk products, breads, pancakes, waffles. It says processed meats, but you'll notice that it also says meat, poultry, seafood, chocolate. Please don't take away my chocolate. Colas, etc. So that would be, actually I'm going to go back for a second. It would be hard to eliminate all phosphorus containing foods from your diet, and it would be very unhealthy. You would not be following the general recommendations for diet. Blood phosphorus is typically elevated in hypophosphatasia. Avoiding excess phosphorus in your diet, especially from artificial food, is probably a good decision for anyone and for anyone's skeleton. So we do tell our patients to avoid dark colas because those are the ones that seem to have a lot of phosphorus. You can just look on the side and see if it says phosphorus, phosphate as part of the ingredient. Processed foods, fast foods, I don't think that that is bad advice for anybody. But in hypophosphatasia, whether or not there's going to be a long-term impact to lowering blood phosphorus, that might be more challenging, even if you were to drop phosphorus down in your diet. And this is a study we just published in which we showed that these growth factors that are phosphatonins, they control phosphorus levels in your bloodstream, are not set in the right position, not the right amount of circulating FGF7 in patients who have pediatric hypophosphatasia, and may explain why people with hypophosphatasia have elevated phosphoruses. So if you already have something going on in your bloodstream that is changed your set point of what your body thinks is a normal of phosphorus, dropping the phosphorus in your diet might not work. If somebody wants to try dropping it to half RDA, it's kind of a painful thing to do. The kids really complained, even though we only did that for 3 days. But I would encourage any physician who's thinking about doing that to do it as part of a very well planned study, and also see whether or not these phosphatonins change, and whether or not there really does seem to be a different set point that no matter what you do, you're still going to have your phosphorus in the same range. Let's move on to vitamin B6. So the vitamin B6 story in hypophosphatasia. Tissue nonspecific alkaline phosphatase cleaves the phosphorus group off of the main circulating form of vitamin B6 called PLP, turning it into PL. So when it's not working well enough, as in hypophosphatasia, will there be less of the processed form, less PL, and more PLP? Well, in neonates and babies with life-threatening hypophosphatasia, the answer is yes. So your intestine absorbs the PLP form and the PL form, and if you want to know what those are, it's pyridoxal 5-phosphate written out the bottom, and pyridoxal. In the liver, you convert it back to pyridoxal 5-phosphate, and then in the bloodstream, pyridoxal 5-phosphate gets converted to pyridoxal, which is the form that can be taken up by cells. And the thing that allows this conversion to occur in the bloodstream is tissue nonspecific alkaline phosphatase that sits on the outside of cells. Here I'm saying it again, PL is the form that can enter the cells. And in the case of babies with neonatal seizures, you'll see that you're having great difficulty changing. I just put on the pointer, it looks like it's the same color. Okay, you have great difficulty changing your main circulating form into the form that can be taken up by cells, because the amount of tissue nonspecific alkaline phosphatase in these babies is so incredibly low. So this is still talking about the babies, and you'll see that your PLP goes up because you can't convert it, your PL goes down, and then you cannot get as much into your cells, and so PLP inside the cells also has decreased. That's the babies with vitamin B6 responsive neonatal seizures. So is PL low in other patients with hypophosphatasia? And I think we know the answer to this, and the answer is no. The amount of tissue nonspecific alkaline phosphatase sitting on the surface of cells that can convert PLP to PL is higher in the patients who don't have neonatal seizures. In 1985, Dr. White showed that circulating levels of PL are normal or elevated in patients with hypophosphatasia who do not have the neonatal or infantile form with seizures. That was 11 patients. At the upcoming ASBMR, we have an abstract showing that 150 patients with hypophosphatasia, with infantile through odontal hypophosphatasia, also have either normal or elevated PL levels. And there's a publication from a couple years ago of 17 Japanese patients showing the same thing. They did have one patient who had perinatal hypophosphatasia and had vitamin B6 responsive seizures, and in that patient there was a low PL level. So in hypophosphatasia without neonatal seizures, yes, you do end up with an elevated PL level, and actually you end up with this elevated PL level even in carriers very often for a TNS-ALP or TNAP mutation without disease. But the PL level in anyone except for the babies with neonatal seizures is either elevated or low, and so there should be enough to get into the cells and get enough vitamin B6 functioning inside a cell. Okay, so if babies with life-threatening hypophosphatasia benefit from B6 supplementation, would it hurt to give it a try in patients with hypophosphatasia without neonatal seizures? And my comment is, don't forget the Goldilocks principle, and if it ain't broke, don't fix it. There is such a thing as vitamin B6 toxicity, skin lesions, GI symptoms, and neurologic symptoms. I don't think you want to give yourself extra problems. And at that, I will close and thank you for your attention. I'd like to mention and acknowledge Shriners Hospital for Children, specifically the one in St. Louis, the Center for Metabolic Bone Disease and Molecular Research, where the work that stemmed from Michael White's group it was conducted. Families and patients with hypophosphatasia, none of this is possible without having an opportunity to get to know you guys and to study hypophosphatasia very deeply. The nursing, laboratory, dietary staff, data manager, statistician, and volunteers who work at this research center, Dr. White and the other doctors of the research center, and our collaborators.